Hey guys, welcome back to my channel, The ENT Resident. In my last video, I have discussed about acute otitis media. And in this video, I'll be continuing that topic and be discussing about the complications that you see in acute otitis media in a little bit more details. Now you can also purchase my notes. I've added the links in the description. So let's get started. So first of all, let's classify these complications that we see in a case of acute otitis media. Now, these complications can be classified into extracranial complications and intracranial complications. Amongst extracranial complications, the most common extracranial complication which is seen in AOM and even the most common complication overall seen in AOM is tympanic membrane perforation. Others include acute mastoiditis, petrositis, facial nerve palsy, and labyrinthitis. Coming to intracranial complications, the most common intracranial complication seen in a case of acute otitis media is meningitis. Others include extradural abscess, subdural empyema, sigmoid sinus thrombosis, focal otitic encephalitis, also known as cerebritis, brain abscess, and otitic hydrocephalus. Now, in intracranial complications, usually there is a common symptoms that we see, which are fever, otalgia, cephalgia, and altered mental status. And in whenever there is a case of intracranial complication being suspected, the investigation of choice will always be a MRI, because MRI is seen. MRI is very useful to see the soft tissue aspects. Now let's start discussing each complication one by one. Let's start with tympanic membrane perforation. So tympanic membrane perforation is actually the most common complication of acute otitis media seen in about 1 to 10% cases. And it is usually associated because the tympanic membrane perforates, it is usually associated with a purulent or bloody otorrhea and an immediate relief of the pain that the patient has been complaining. If you see in the image over here, you can see there is a perforation in the antero-inferior quadrant and there is a purulent otorrhea being seen in the external auditory canal. Now, typically, it happens in the posterior half of the pars tensa. The most common organism seen to be causing this in decreasing order of frequency, first is Haemophilus influenzae, second is Streptococcus pneumoniae, and third is Moraxella catarrhalis. Now, when a tympanic membrane perforation happens, the location and the site at which it has happened correlates with the resulting degree of hearing loss, with larger perforation and those located in the antero-inferior quadrant leading to a larger conductive hearing loss. Now, when tympanic membrane perforation happens, what are the possible outcomes it can end up in? So, the first outcome it can end up in that the perforation can heal very spontaneously and the infection resolves by itself. This happens in majority of the cases. Second is the infection resolves by itself, but however, the perforation continues to persist. And this may predispose the ear to a future acute otitis media or even a chronic suppurative otitis media. Third outcome is that the perforation and the otorrhea both persist, manifesting as a case of chronic otitis media. And chronicity is deemed to have occurred only if it has remained for 3 months. And the fourth and final outcome is that it leads to a further complication, which we'll further discuss now. So this was about tympanic membrane perforation, which is the most common complication of acute otitis media, also the most common extracranial complication of acute otitis media. Second is acute mastoiditis. Now, what are the different types of acute mastoiditis that we see in a case of acute otitis media? There are 3 types. First of all, during episodes of acute otitis media, infection and inflammation may naturally extend into the mastoid cavity, and this can be visualized radiologically. However, this does not classify as a complication of acute otitis media because we also do not see the typical signs of acute mastoiditis over here. This is just the trickling of the pus inside the mastoid cavity. Second, the infection may actually spread to the mastoid periosteum through the emissary veins. This leads to the formation of acute mastoiditis with periostitis. In this case, usually there is no abscess present. Post-auricular crease is seen to be full. If you see in the image over here, you can see that there is no delineation of the post-auricular crease. It kind of feels very full. The pinna, it gets pushed forward, and there is a mild swelling, erythema, and tenderness in the post-oral region. You can see in the image over here, this is the post-oral region. You can see the mild erythema over here, the mild swelling, the post-auricular crease being full, and the pinna getting pushed forward. The third type is when acute mastoiditis, mastoid osteitis develops, the infection can actually start to destroy the bone of the mastoid air cell and subsequently leads to the formation of a subperiosteal abscess. Now, when a subperiosteal abscess forms, the signs will be very similar to the previous one that I was discussing. Now, subperiosteal abscess most commonly, you can see in the image over here, this is the subperiosteal abscess. It most commonly occurs in the post-auricular region. And from here, a zygomatic abscess can also develop, which zygomatic abscess forms in front and above the pinna. There's another abscess known as Bizold abscess, which develops from perforation of the medial mastoid cortex, and it starts going along the sternomastoid muscle to reach the posterior triangle of the neck. This abscess will be known as the Bizold's abscess. And sometimes the pus can even track down peritubal cells and leads to retropharyngeal or parapharyngeal abscess. So as the subperiosteal abscess develops, it can actually lead to formation of multiple other types of abscess depending on which direction it proceeds in. And the fourth type that we see here is a subacute or masked mastoiditis, where this is usually happening when there is an incomplete treatment of the acute otitis media after 10 to 14 days of infection. In this type, we do not see any signs, only otalgia and fever is present, and this type has been seen to progress to severe complications more often. So these were the four types of mastoiditis that we can see. The first, however, does not classify as a complication of AOM. Now let's discuss what are the clinical features that these patients come to you with. Very commonly, this is actually a disease of childhood, most commonly seen in children under the age of 2 years. It is usually preceded by 10 to 14 days of middle ear symptoms, followed by the development of acute mastoiditis. The common symptoms are ear pain, irritability, discharge in the ear, and fever. Signs, as I have already discussed, we'll see a post-auricular swelling, the protrusion of pinna forward, post-auricular erythema and tenderness over the McEwen's triangle, a red or bulging tympanic membrane. The first image over here, I have already discussed this image, the pinna getting pushed forward and the tenderness and erythema over the McEwen's triangle. The second image over here is showing the presence of a very reddish bulging tympanic membrane. It's also not necessary that you always see a reddish bulging tympanic membrane. You can also see a normal tympanic membrane, and that does not exclude the diagnosis of acute mastoiditis. Because in these cases, it is believed to result from resolution of the mesotympanic infection following the use of antibiotics. However, even though antibiotics are being given, the osteitis in the mastoid keeps on progressing, and that leads to the formation of acute mastoiditis. The third image over here shows you the sagging of the posterior wall of the external auditory canal, and this is usually seen due to the development of subperiosteal abscess. So these are the clinical features of acute mastoiditis. Now, what are the most common organisms that we see causing it? Most common one is Streptococcus pneumoniae. Next is Streptococcus pyogenes, Pseudomonas aeruginosa, Staphylococcus aureus. And Pseudomonas aeruginosa affects children and cases of ventilation tubes more often. The typical investigations done are the complete blood count, CRP blood cultures, and CT scan of the mastoid, where we do a CT scan with contrast, is indicated when in three particular cases when we suspect that there can be an intracranial complication. Second, when mastoidectomy is performed. And third, those who are not responding to antibiotic treatment. The differential diagnosis in these cases would be acute otitis media, otitis externa, furunculosis, reactive lymphadenopathy, undiagnosed cholesteatoma, vaginous granulomatosis, and histiocytosis. Coming to treatment of acute mastoiditis. The treatment primarily involves the usage of parenteral antibiotics with or without myringotomy. And the drug of choice over here is either third generation cephalosporins or a combination of aminopenicillin and a beta lactamase inhibitor. If we suspect that there is a pseudomonas infection, in that case we should use ciprofloxacin, piperacillin, or fosfomycin. Secondly, cortical mastoidectomy is usually done when the patient is not responding to conservative treatment, and second, there is a suspicion of intracranial complications. However, before doing a surgery, we should observe the patient for 24 to 72 hours before proceeding to do the surgery. The only case where we do not wait is when there is a presence of subperiosteal abscess, unwell child, and a deteriorating clinical picture. All of that will lead to rapid intervention in the form of surgery. So, this was all about acute mastoiditis. Next, let's talk about Petrositis. Petrositis is basically when the infection has extended to involve the petrous apex of the bone. And a very characteristic triad is seen in case of Petrositis, which is known as Gradenigo's triad. And what are the three features of Gradenigo's triad? First is the presence of diplopia, which occurs due to lateral rectus palsy, which happens because of the involvement of the sixth nerve, which passes through the petrous apex. Second is the presence of periorbital pain due to trigeminal nerve involvement. And the third feature of the triad is persistent otorrhea. This Petrositis is usually seen to be present with other intracranial complications. If you see in the image over here, this is a CT scan which shows the yellow arrow points towards the petrous apex area. There is involvement of the bone over there. Treatment is usually surgical, where we perform a minimum drainage of mastoid and decompression of the petrous apex. Next complication is facial nerve palsy. This is very rare. It is seen in about 0.005% cases. The most common bacteria causing it is Staphylococcus aureus. The pathophysiology behind this is that neuropraxia happens secondary to edema or nerve compression or to bacterial toxic metabolites in congenitally dehiscent facial nerve. And in these cases, the treatment usually involves putting in a ventilation tube and IV antibiotics. 80% patients respond to that. Cortical mastoidectomy is performed only in cases which are failing on conservative treatment or exhibit poor electrophysiological tests. And third, use of corticosteroids also have been used. Next is labyrinthitis. Now, labyrinthitis, there are two types of labyrinthitis that we see in these cases. One is serous labyrinthitis, and second is suppurative labyrinthitis, which is the more rare form. Now, serous labyrinthitis is when there is an inflammation of the labyrinth without any pus formation. And basically, these patients are a non toxic patient. You see a sensory neural hearing loss and vertigo. Conductive hearing loss can also be present because of the presence of fluid. These patients have been seen to undergo a complete and a very rapid recovery of their auditory and vestibular function. Now, the second type is suppurative labyrinthitis, which results from a spread of infection from mastoid or middle ear, and this may raise suspicion of an anatomical defect or any immunodeficiency. Now, these patients present with severe vertigo, nausea, vomiting, nystagmus, and a permanent hearing loss. MRI will show a contrast enhancement of the labyrinth. And these cases are treated with antibiotics and ventilation tube, tympanomastoidectomy, cochleotomy, and steroids may prevent this if it is used in the initial phase of the disease. So, this was all about the extracranial complications. Now, let's discuss all the intracranial complication, starting with the most common intracranial complication of acute otitis media seen in about 50 to 90% cases, and that is meningitis. Now, the most common bacteria involved here is Streptococcus pneumoniae, and the common symptoms seen in these patients are headache, fever, vomiting, photophobia, irritability, restlessness, and if the child is below 22 months old, then there is a fullness of the anterior fontanelle seen in these patients. Diagnosis is very easily made on the clinical presentation. A lumbar puncture done in these cases will show raised WBC and low glucose in the CSF. And treatment of these patients, usually the mainstay of treatment is antibiotics, and the drug of choice is third generation cephalosporin. However, if you find resistant strains, in those cases, vancomycin is used. Mastoid surgery is rarely required in these cases. Even though if it is required, it is best to wait for improvement in the medical condition of the patient first before you start to proceed the surgery. This is about meningitis. Next, let's talk about extradural abscess. Extradural abscess is the second most common intracranial complication which is seen in acute otitis media. What happens here is that pus starts collecting between the dura and the bone after there is bone erosion. And this can lead to two possible outcomes. One is if this lies in the posterior fossa medial to the sigmoid sinus, it will lead to the formation of extradural or epidural abscess. However, if this lies within the split of a dura enclosing the sigmoid sinus, it leads to the formation of perisinus abscess. Usually, the clinical features are the same as other intracranial complications, and treatment involves a surgical drainage. Next kind of abscess is the subdural empyema. This is a very rare complication, and what happens here is there is a collection of pus between the dura and the arachnoid matter. It usually develops as a direct extension of the infection or thrombophlebitis. We see common clinical features as other intracranial complications, and treatment usually involves a surgical drainage of the abscess through burr hole or craniectomy, and the case also needs a mastoidectomy. Next, let's discuss about sigmoid sinus thrombosis. This is a very rare complication seen in about 0 to 2.7% cases. And how does it happen? First, what happens is there is an erosion of the bone over the sinus from mastoiditis, because of which an infected thrombus starts developing within the sinus. Now, this infected thrombus can actually extend proximally and distally to involve the internal jugular vein and the superior vena cava. From there, it enters the systemic circulation and leads to the development of septicemia. A patient of sigmoid sinus thrombosis will come to you with intense headache, otorrhea, and spiking fever. The fever in this case is actually known as picket fence fever. And there is a very common sign that we see here in these patients is known as Griesinger's sign. Now, Griesinger's sign is basically when there is mastoid tenderness and edema secondary to the thrombophlebitis of mastoid emissary vein. You can see in the image over here, this is what Griesinger's sign looks like. You can see some tenderness and erythema over the mastoid area and edema, which is secondary to the thrombophlebitis of the mastoid emissary vein. The investigation of choice over here is usually a MRI, where we see a acute clot as isodense on T1 and hypodense on T2, and a subacute clot which becomes hyperintense on T1. Treatment usually involves conservative surgery with anticoagulation. This is the most common treatment given. Antibiotics involve ceftriaxone, metronidazole, and clindamycin. There are other surgical treatment options, which includes myringotomy with or without ventilation tube, mastoidectomy with or without delamination of sigmoid sinus, needling of sinus thrombectomy, internal jugular vein ligation and craniotomy, and post-operative anticoagulation, which is only given if there is no associated intracranial hemorrhage. So this is about sigmoid sinus thrombosis. Next, let's move on to focal otitic encephalitis, which is also known as cerebritis. This condition is basically there is a focal inflammation and edema of the brain tissue, which can either happen independently or in association with any other suppurative complication of acute otitis media. The treatment usually involves intensive antibiotic therapy. Next complication is brain abscess. Now, the common sites involved in the brain abscess is the temporal lobe and the cerebellum. The most common causative organism is a Streptococcus pneumoniae and sometimes even non-pneumococcal streptococci. The patient presents to you with persistent headaches. Initial symptoms can be that of resembling encephalitis, but they often settle as the abscess organizes over days to weeks. There will be signs of raised intracranial pressure and focal neurological deficit. Investigation usually involves a CT scan followed by lumbar puncture, and treatment involves broad spectrum antibiotic mastoidectomy and neurosurgical drainage. Coming to our last complication, which is otitic hydrocephalus. Now, this is a complication of acute otitis media, which manifests as raised intracranial pressure in the absence of any space occupying lesion and without any obstruction to the flow of CSF. Whenever you're seeing that the intracranial pressure has actually risen, however, there is no obstructive pathology being found, this leads to a suspicion of otitic hydrocephalus. The other name for this is benign intracranial hypertension. The predominant symptom seen over here is headache. Other than that, the patient also complains of drowsiness, vomiting, visual disturbances, basically all complaints that can come as a result of raised intracranial pressure, like diplopia, signs of papilledema, even leading to abducens nerve palsy, leading to lateral rectus palsy. This condition is also commonly associated with sigmoid or transverse sinus thrombosis. Investigations involve MRI or MR venography, and lumbar puncture will show a raised CSF pressure but a normal CSF composition. Treatment of this includes corticosteroids, mannitol, diuretics, acetazolamide. Basically, the treatment is directed towards reducing the intracranial pressure. So that completes all the intracranial and the extracranial complications seen in a case of acute otitis media. If you have any other questions, please note them down in the comment section and I'll get back to you.